Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in.
Today, we're focusing on pregnancy and childbirth. Let's get started with a lecture brought to you by Paige, one of our content creators. Then we'll wrap up with 10 multiple choice questions for review.
Welcome to EMT class. Today we are going to take a really deep dive into pregnancy and childbirth and everything that's involved with the two. So we're going to go over female anatomy. It's like a quick overview. We're going to go over conception and fetal development, which is super important to understand the physiology of it. We'll go over physiology of pregnancy, so the things that happen in the female body that would affect you in the field. So if you were to respond to a pregnant lady, these are the things that you would need to know are going on inside of her body. Assessment, care, and interventions of childbirth itself. So this is not just pregnancy, this is actual childbirth. We'll go over normal, uncomplicated childbirth, and then we'll go over some complicated childbirth, which would be outside of the scope of an EMT basic, but it's important to understand. And then pregnancy-related complications. So sometimes that would be actual childbirth complications, and sometimes it's just pregnant. So this is the female anatomy, the female reproductive system, and these are the important pieces to understand. The uterus is an organ made primarily of muscle where the fetus develops during pregnancy. So that's kind of where it lives. The ovaries are the primary reproductive organ for females. They release an egg, sometimes called an ovum, each menstrual cycle, and this is the source of fertilization. So without ovaries, a woman cannot become pregnant. So if she's had a hysterectomy, or she's had ovarian cancer and she's had these pieces removed, or she's hit menopause, she can no longer be pregnant. So it's always important to ask those questions to any childbearing female. The fallopian tubes are those long, skinny pieces that you see. That is the connection between the uterus and the ovary, and this is typically where fertilization occurs originally, and then it kind of travels down and it implants in the uterus. Cervix is the neck, or the lower end of the uterus. That's what dilates when a patient goes into labor. So when a physician checks for dilation, that's what they're checking, is the cervix and the vagina. And then the vaginal canal, or the birth canal, happens in the vagina. And it's a tube-like structure that connects the cervix to the external genitals. So most of the time, if you would have to do some sort of intervention, you are not. The only piece of this that you're going to see on the outside is the vaginal canal. The rest of this is far deep inside of the woman, and so this is all internal structures. So while you may think like child development is something that happens during infancy, the prenatal period is actually considered a really important piece of this. Prenatal development is the time of remarkable change, so tons and tons of change that helps set the stage for future psychological and physiological development. So the germinal stage begins at conception, when the sperm and the egg meet in the fallopian tube, and that fertilized egg is now called a zygote. So it changes from being just the egg into the zygote because now it is fertilized. And so the zygote's cells begin to divide rapidly, and after approximately 3 days of division, the zygote transforms into a blastocyst, and the blastocyst is actually what connects to the uterine wall. So that's what will eventually attach. The blastocyst is made up of 3 layers: the ectoderm, the endoderm, and the mesoderm. And those are important vocabulary words for you to remember. The brain develops over the course of the prenatal period, but it will continue to grow through more changes during the early years of childhood, obviously. So you can see in this picture that we have pieces of the brain that are starting to form in the embryonic stage, and we haven't reached that. So we're still germinal at this point. So that big picture of the cells, that's where we're sitting. The ectoderm creates the skin and the nervous system. The endoderm creates digestive and respiratory systems, and the muscle and the skeletal systems are the mesoderm. The blastocyst arrives at the uterus and attaches to the uterine wall, a process known as implantation, another good vocabulary word. An implantation occurs when a cell nestles into the uterine lining and ruptures tiny blood vessels. So you can get what's called breakthrough bleeding or implantation bleeding. That happens sometimes when it implants because it breaks those little vessels. The connective web of blood vessels and membranes that form between them will provide nourishment for the developing being for the next 9 months. So this starts the connection between the mother and the infant, or the mother and the fetus. Implantation is not always an automatic and surefire process. So sometimes you can implant and then they detach and then implant again. Sometimes they will implant and detach and then the fetus will no longer survive. So once the blastocysts implant into the uterine wall, the woman's body will signal to the brain that implantation has occurred and menstruation will cease. So she would no longer have a period at that point. After this point, the blastocyst is now known as an embryo. So now we're moving into that second stage that you're seeing on that picture, the embryonic stage. This is between 3 to 8 weeks. The embryonic stage lasts until the 8th week of pregnancy, in which the mass of cells is now distinctly human. So between 0 and 8 weeks, the cells are no different than some of our relatives on the kingdom, right? The kingdom of like animals and plants and like that. By the end of the embryonic stage, the basic structures of the brain and the nervous system are present. So if we go back a little bit, the beginning of the 3rd week after conception marks this time, and this plays a super, super important role in the development of the brain. And that's why in this picture that you see, it's very specific. It's showing you that you're going to get a forebrain, a midbrain, a hindbrain, and not all animals have that. So this is starting to become more and more human. The neural tube develops at week 4 usually, and this tube will later develop into the central nervous system, including the spinal cord and the brain. So that yellow tube-like structure that you're seeing that's forming along the back side of that fetus, that is the neural tube. The neural tube begins to form along the area known as the neural plate. And the earliest signs of development of the neural tube are the emergence of 2 ridges that form along each side of the neural plate. So it's kind of beginning to form the spine is what it's eventually going to be. Over the next few days, more ridges form and fold inward until a hollow tube is formed. Once this tube is fully formed, cells begin to form near the center. The tube begins to close and the brain vesicles form. So it's developing not only the spine, but also pieces of the brain and creating the brain itself. So it's like a big hollow organ that will eventually fill. These vesicles will eventually develop into parts of the brain, including structures of the forebrain, midbrain, and hindbrain. Around the 4th week, the head begins to form, differentiating itself from the body, and you will start to get eyes, nose, ears, and mouth on the fetus, and the blood vessel that will become part of the heart starts to pulse. So at about 4 weeks is when you can detect a heartbeat on an ultrasound, so it's important to remember that development stage. That's kind of important, that at the 4th week, a physician might be able to find a heartbeat. During the 5th week, buds that will form the arms and legs appear. And by the 8th week of development, the embryo has all the basic organs and parts except those of the sex organs, so they're neither male or female. At this point, the embryo weighs just 1 gram and is about 1 inch in length. So you can see that there's a ton of things that are happening when the fetus is just absolutely tiny. The female might not even know she's pregnant at this point, and this is a stage where we see a lot of miscarriages happen. And again, the female may not know she's pregnant, nor may she know that she's having a miscarriage. So once cell differentiation is mostly complete, the embryo enters into a new stage of development, and it is now known as a fetus. This period begins the 9th week of pregnancy and continues until birth. So starting 9 weeks and until the baby is born, it is known as a fetus. It's important that we don't call it an infant, so it's different. A fetus is before birth and infant is after birth. Fetal development is vital for the survival of the fetus and occurs at an exponential rate from months 3 through 6. So where are we sitting at week 9? We have body systems and structures that are established, and they were established in that embryonic stage, right? We have the neural tube, we have the brain and the spinal cords and the neurons that are forming at this point. We have synapses. Those are beginning to develop around 8 to 9 weeks. Between the 9th and the 12th week of gestation, reflexes begin to emerge. So the fetus begins to make reflective motions with its arms and legs. So sometimes this is when the mom can begin to feel the baby move. During the 3rd month of gestation, the sex organs begin to differentiate. And by the end of the month, all parts of the body will be formed. At this point, the fetus weighs around 3 ounces, so still super, super tiny. And the fetus continues to grow in both length and weight, although the majority of physical development happens later in the pregnancy. The end of the 3rd month also ends the 1st trimester of pregnancy. During the 2nd trimester, or months 4 through 6, heartbeat grows stronger and other body systems become further developed. Fingernails, hair, eyelashes, toenails, those things begin to form and are complete. And then the fetus increases about 6 times in size. So there's a ton of development that happens in the 1st trimester, but there's not a lot of growth. So lots of things are forming and happening, but not a lot of growth. In the 2nd and 3rd trimester, you're seeing a ton of physical growth, and that's when you'll start to see the mom start to show. So what's going on in the brain during this important period? The brain and central nervous system become more responsive during the 2nd trimester, around 28 weeks. The brain starts to mature faster with an activity that resembles that of a sleeping newborn. So they're going to have things like hiccups. They have a gag reflex even. There's lots of things that happen that inside the brain that affect that fetus. From 7 months until birth, the fetus continues to develop, put on weight, and prepare for life outside the womb. The lungs begin to expand and contract, preparing the muscles for breathing. So the fetus isn't actually breathing because there's no oxygen out in the air, but their lungs are moving. So we start at the germinal stage, then we move to the embryonic stage after implantation. That is from weeks 3 through 8. And then the fetus and fetal development happens 9 weeks all the way up until the baby is born. So the fetal development is a huge stage of development in the baby's lifetime. So this is a picture of placental vessels, the placental cord, the fetus inside of the little sac. So you're beginning to see the formation of the placenta. The placenta is what feeds the baby, gives the baby oxygen, and gets rid of things like waste from the implantation all the way up until birth. So maternal blood pressure normally decreases or remains unchanged during pregnancy, while both cardiac output and vascular volume are increased because of this placenta. So you have to think that the mom is having her own circulatory system, and she's feeding the circulatory system of her fetus. So that makes sense that her blood pressure might drop a little bit and her cardiac output and vascular volume are increased because her heart is having to work a little bit harder, and her vascular volume, she's creating a whole other human being. So that makes sense as well. Uterine blood flow changes are principally due to decrease in uterine vascular resistance. There is also an associated structural enlargement of both the uterine arterial and venous trees. That makes sense, right? So the structures inside of her belly are going to impact the structures of the fetus. And there's going to be reduced vascular tone, aka vasodilation, and placental development. So essentially, that just means that the function of the placenta is to provide nutrition, gas exchange, and waste removal. And because of that source for the fetus, it's going to affect the mother. And that you can see that with vasodilation, you can see that with mild hypotension, increased cardiac output. She might have a higher heart rate, her temperature might be a little bit higher. all of these things are secondary to the fact that she's got a placenta and she's feeding a fetus. So fetal circulation, this is kind of a big idea, but essentially I want you just to follow along to the picture. Let's start at the aorta. So the aorta is this big purple structure, and then you get your vena cava, that's the blue one. And so the blue one feeds into the red piece that fills into the placenta. So this is called the umbilical vein. So it's feeding from the mother, and at the ductus venosus, it changes into the thing that goes to the fetus. So the umbilical vein feeds to the placenta. That's where gas exchange happens. And then the purple is what comes back and gets circulated through the mother. So it's one big long loop, and you have both oxygen-rich blood and oxygen-poor blood. And the vein that comes from the placenta, that purple one that you see, that's mixed. So you're going to have some waste, you're going to have some oxygen-rich, oxygen-poor blood both in there, and that's to help with the gas exchange. So anatomy during pregnancy. During the course of pregnancy, the uterus grows up to 6 times the normal size. So that's a huge change. And if you saw what the size of a uterus is without an infant in it, it's really tiny. So when you have the fetus inside of the mother, it can grow up to 6 times its size. The pelvic structure changes and widens to allow for childbirth. That makes sense, right? So our hips are not meant to carry another human being in them. And so they will turn outward and widen and allow for eventual birth. Placenta forms and connects the fetus through the umbilical cord. You get progressive vasodilation, like we were talking about, higher blood flow to the uterus and breasts, higher angiogenesis. So what's angiogenesis? That's the development of the new vessels. So think like the placental tree. You have new ducts in the breasts. So you have higher development of new vessels, higher leukocytes concentration. So this occurs during the pregnancy, and it's due to the physiologic stress induced by the pregnant state. So you're just going to have a higher white blood cell and increased pressure to the superior vena cava. That makes sense because you're going to have that fetus sitting down and increasing the pressure on that big vena cava. So we see definitely a lot of changes that happens to the female's breasts. So we get duct and alveoli hyperplasia. So that's the enlargement of an organ or tissue caused by an increase of the reproductive rate of its cells, aka they grow, they get bigger. You get duct and alveoli hypertrophy, increase in immune cells. That's because it's made for if the fetus is going to breastfeed, you're helping build their immune system. Increase in both lymph and blood cells, and production of precolostrum. Colostrum is the first form of milk produced by the mammary glands immediately following the delivery of a lot of like humans and animals will begin to generate colostrum just prior to giving birth. So we get some before the infant is born and after. We see hair and nails remain in the growth stage. So a lot of women really, really like being pregnant because their skin is glowy, their hair and nails are super long and strong. That's because they have a really big influx in estrogen. And so their hair and nails don't get out of the growth stage. After birth, however, you do lose your hair and your nails kind of get brittle. That's because you have a big downward trend in your estrogen. We have hyperpigmentation of skin. So this is kind of interesting. So the physiology of hyperpigmentation appears to be related to the increased production of estrogen, but it's perhaps maybe due to increased levels of progesterone or a melanocyte stimulating hormone. They're not super sure, but you definitely do get hyperpigmentation. Sometimes on the face, sometimes on the belly. You do form what's called a linea nigra. So that is that line down from the belly button that you see on pregnant women. All pregnant women get it. It goes away after you give birth. Changes in oral health. So you're prone to bleeding gums. due to hormone changes that make your gums more susceptible to normal bacteria in your teeth. You get decreased motility and slower digestion, changes in composition of bile, redistribution of extracellular fluids. So you get swelling of your limbs. That's super common, particularly of the ankles and of the feet. Gastric reflux, esophagitis. Some women experience this really strange phenomenon of severe itching in late pregnancy. The most common cause of this is cholecystitis, a common liver disease that only happens in pregnancy. There's just a lot of things that happen during pregnancy to the woman that's not directly related to the fetus. So sometimes you will get women who, maybe have some bleeding or something, and then when you get her into the back of the ambulance, she'll tell you of a couple of other things that are bothering her, and these are all normal. So if she's having some gastric reflux, if she's having swelling of her limbs, those are all normal things that happen during pregnancy. The swelling, or in EMS call it edema, that occurs because of the body fluid increase to nurture both mom and the baby and accumulate in tissues as a result of increased blood flow and pressure of the growing uterus on the pelvic veins and the vena cava. So it's not able to feed back to the heart as well because of that increased pressure. So we definitely see a lot of hormonal changes in a pregnant woman, and a woman experiences a major change to her entire endocrine system. There is a rapid increase to both progesterone, which is produced by the corpus luteum, and estrogen or oestrogen produced by the placenta. So we see an increase in estrogen levels that result in an increase in hepatic production of the thyroid binding globulin, or TBG. As a result, you see more free T3 and T4 levels, and they bind to the TBG. That this causes more thyroid stimulating hormone to be released from that anterior pituitary gland, and therefore the free T3 and T4 levels remain unchanged, but the total T3 and T4 levels rise, if that makes sense, because it's binding to that increased TBG. Thyroxine is essential for the fetus's neural development, but the fetal thyroid gland is not functional until the second trimester of gestation. So the increased T3 and T4 levels in the mother ensures that there is a constant supply of the things that the thyroid gives you. During pregnancy, mainly during the second trimester, really, there is an increase in human placental lactogen, prolactin, and cortisol levels. These are anti-insulin hormones, therefore they increase insulin resistance in the mother and reduce peripheral uptake of glucose. This ensures that there is a continuous supply of sugar to the fetus, essentially. The mother switches to an alternative source of energy, which is provided by lipids. This increase in the uptake of lipids means that there's an increase in free fatty acids in the plasma, which provide substrate for the maternal metabolism. So that makes sense, right? If you take away her ability to burn off that glucose, she has to have a different way to get energy. So you do see some women go into ketoacidosis because she kind of goes into ketosis, burning that lipids, right? And so that's something to kind of keep an eye on if she's got super, super high blood sugar. So we're going to switch from talking about the changes that happen in pregnancy and the maturation of the fetus, and now into the assessment, care, and intervention of childbirth. So this is what happens when a woman goes into labor and what to do in it. So airway, breathing, circulation, this is first, always and forever, regardless of what's going on with the patient, right? You do a normal sample, you do a physical assessment. So these are all normal things, right? We always ask our sample questions. We always assess their ABCs, and we always do a hands-on physical. However, with a pregnant woman, there are a couple other things that you need to be looking for. So if you can do fetal monitoring with a fetal monitor or ultrasound or something like that, that would be great. A lot of agencies don't have that ability. That's okay. You can do fundal measurement and checking for crowning. So the fundal measurement is kind of how to guess how far along the patient is. That would be for like maybe an unconscious patient, a patient who doesn't know how far along she is. And then checking for crowning, that's only if she's in labor, right? We don't need to be checking for crowning if she's not in labor or doesn't appear to be in labor. And then you want to ask specific questions regarding that. So her last known period, if she's been getting prenatal care, she's going to know that. Is she getting prenatal care? Where is she getting that prenatal care? Is she taking prenatal vitamins? Those are all important. What's her due date? Again, if she's been getting that prenatal care, she's going to know the approximate due date. And then how many parity and her gravida. So how many times has she been pregnant? How many times has she given birth? So sometimes those can be two different numbers, right? And then you want to know, was it an abortion? Was it a miscarriage? Did she have a child and they didn't survive? So like a stillbirth. So you need to know. So the premonitory signs of labor. So what are the things that are going to tell us that a patient is going into labor? So lightening. This is the movement of the fetus into the true pelvis. The lay term of this is dropping. So the baby has dropped. This is a misnomer because the muscles are pushing the baby. It doesn't actually drop, but the muscles are stronger in prima gravida. So that means the muscles are going to be super strong in someone who has never given birth before. This occurs 2 weeks before labor if the patient has never given birth. So the baby will quote unquote drop and becomes easier to breathe for the mom. She feels like she has a little bit more room. Her urinary frequency is going to increase because it's sitting on her bladder. The mom is really going to know if the baby has quote unquote dropped. Also, they're probably going to be visiting their doctor a lot, and so the doctor can tell them as well. They might be experiencing Braxton Hicks. They have really been occurring the entire pregnancy, but the mom only becomes aware of them towards the end, and they do not cause cervical dilation. So this is what differentiates Braxton Hicks contractions from true contractions, is if the cervix is dilated or not. Who's going to tell you that? A doctor or a physician. So sometimes a patient might call you and say that 3 days ago she saw her physician, she was 2 centimeters dilated, and now she's having contractions. So that means those are signs of labor, not Braxton Hicks. A bloody show, this is not active bleeding. It's appearance of a blood-tinged mucus from the vagina. This is the partial dislodgement of the mucus plug. And then the cervix begins to soften and become quote-unquote ripe, but that's what the bloody show is. Or the rupture of the membranes. So this is also commonly known as your water breaking. So it's a sudden gush or persistent leak of water or fluid. You go to the hospital to check for a ferning pattern, and this is what you see on that picture. Or in nitrazine paper, they'll use that to see if there's an alkaline reaction. If you go to a physician or you respond to a physician's office and they tell you that the patient is having cervical changes, if it's called effacement, that means it's the thinning of the cervix. And before labor, the lower part of the uterus, called the cervix, is typically between like 3.5 to 4 centimeters long. But as labor begins and the cervix softens, it shortens and thins, called effacement. They might feel uncomfortable and they might have irregular, but not super like painful contractions, or maybe nothing at all. And so this is really only something a physician will be able to tell. So labor is described in 3 different stages. Together, these stages complete the delivery of the fetus and the placenta. So if you have never assisted in delivering a baby in the field, join a club of lots of EMTs and paramedics. I had never delivered one, and I didn't really think about the fact that the patient was going to deliver the placenta after the fetus was out. So it's okay to be a little bit scared. It's okay to not know what's coming, but that's why we talk about these stages, so that you know how long they're going to be, so you're not freaking out thinking that maybe it's taking too long, and that so you're prepared for all of the things that you will see. So during the first stage, the woman reaches full cervical dilation. This begins when the contractions start and is the longest stage of labor. And the first stage is divided into 3 phases: the latent, the active, and the transition. In the latent phase, contractions occur more often, become stronger, and become more regular. During this phase, the cervix thins, they become fully effaced. The latent phase varies from woman to woman and from labor to labor. So you're going to see a long stage 1, usually from, 10 to 30 hours if the patient has never given birth before. For first pregnancies, it may last longer, from 20 to 30 hours, kind of like I said. But it may be close to 10 for a woman who's had children before. Many women confuse the latent stage of labor with Braxton Hicks contractions, and membranes may rupture in the early to mid portion of the first stage of labor. If they rupture, the labor process often speeds up. If her water has broken, I would prepare yourself at any moment to go into stage 2. The next portion of the first stage of labor is the active phase. During this phase, the cervix dilates rapidly. A lot of women go from 3 to 4 centimeters up to 8 or 9 centimeters during this stage. The active stage is really the most predictable, lasting an average of 5 hours in first-time mothers and 2 hours in mothers who have given birth before. And then finally, there is the transition phase. During this phase, the cervix dilation continues to dilate, but at a slower pace, until they are fully dilated. In some women, the transition phase is not really noticeable, kind of blends into the active phase, but this is also a phase of more rapid descent when the baby is passing lower into the pelvis and deeper into that birth canal. In mothers who have no anesthesia, so the women that you're going to be dealing with out in the field, they might have nausea, vomiting, uncontrollable shaking. This is extremely painful for them. This is probably one of the most painful pieces. And these symptoms can be pretty frightening to watch and experience, but they're part of a normal birth. So if you have a woman who's, profusely vomiting, she's shaking, she's extremely diaphoretic, she's really flushed, that can be pretty scary to watch. But that's all part of a normal birth and the signal that the first stage has been completed. Then you enter into stage 2. So the second stage is the delivery of the infant. So if you see that, you have to prepare yourself essentially for imminent birth. During the second stage, the mom is actively pushing out the baby. For first-time mothers, this can take up to 2 to 3 hours. So it's important to, save your energy, pace yourself. If it's their first birth and they are barely crowning, you might be able to make it to the hospital before delivering in the field. For second babies and beyond, the second stage often lasts less than an hour and sometimes only a few minutes. So if you have a patient who's had 3, 4, 5 babies before, prepare to catch, because that baby is going to be coming very quickly. If they have an epidural, the second stage may require more time. You're really not going to have a patient who's had an epidural, but if you did go to paramedic school and you went to the delivery unit, you might see a woman who has had an epidural. So it kind of takes a little bit more time. So stage 2 ends when the baby has been delivered officially. In stage 3, this is the passage of the placenta. This may occur right away or take up to 30 minutes. The process may be sped up naturally by breastfeeding, which releases oxytocin. Paramedic can give a drug called Pitocin also. So there's lots of stages. There's 3 in stage 1, and there's 2 and 3. There's lots of things going on in labor, and they can all look really scary, but it's good to know what's coming, right? So we see the baby move in a really predictable manner for a normal birth. So you'll see the onset of labor. They're all kind of scrunched up in their little uterus. They flex. And that's when you're going to start to see the end of that first stage and to the second stage. So this is the very painful portion. This is when you can see the nausea, the vomiting, the diaphoresis is in the flexion stage. Then the internal rotation of the head. This is going to be during active labor and pushing. And so in a normal birth, you will see the back of the infant's head crowned first. So you'll probably see a little patch of hair. Extension is when the baby's head comes out. And then naturally, they have an external rotation of the head. Sometimes you might have to help with that. That's so that you can deliver the shoulders and the hips. And then the uterus immediately after birth kind of shrivels and the placenta separates from the uterine wall. So it's going to continue pushing till that placenta is out. And then you obviously see the umbilical cord is still attached to that placenta. So the placenta, there's lots of different problems that can happen. This is a picture of a placenta after birth. So you can kind of see that tree of life right there. That's the outside of the placenta with the umbilical cord still attached. So you can get placental abruption, placenta previa, placenta accreta, retained placenta. These are all problems with the placenta that can cause a lot of bleeding. And signs and symptoms of placental problems is vaginal bleeding, abdominal pain with or without trauma. So you can have like placental abruption before the patient gives birth. Placenta previa, placenta accreta. Those are all before the patient gives birth. Back pain, torn placenta after birth can tell you that you have retained placenta, so you still have placenta inside of it. If you have a normal delivery, the patient is not having twins, it's not been a complicated pregnancy, all of the things are setting yourself up for a normal delivery. If you are deciding to deliver on scene or transport, this is what you want to consider. The patient's previous pregnancies, particularly how many. If she's had a lot of babies, you probably want to deliver on scene because you're not going to make it to the hospital. But also, did she have postpartum hemorrhage? Did she have problems with her last pregnancy? Did she have a stillbirth? Those are things that you want to know. How long was her labor in previous pregnancies? Sometimes that's applicable, sometimes that's not. It really depends. The frequency of contractions, are they really like stacked up back to back? That's probably a sign that you should just deliver on scene. Does she have the urge to push? Again, that's a sign that maybe you should deliver on scene rather than transport. And then crowning, obviously, if your patient is crowning, you need to deliver it on scene. You're not going to make it. You don't want to be delivering in the back of an ambulance while moving 75 miles an hour down the road. You would want to transport immediately if her water broke more than 24 hours ago. If she has an abnormal presentation, we'll go over that, but like breech or footling or something like that. Baby's in distress. So you either could tell that with a fetal monitor, or you might get a call to like a home birth or a birthing center or something like that. And someone will tell you that the baby is in. And the presence of multiple fetuses, you want to start transporting because usually they come early. A lot of times they have complications. So if you're having twins or triplets or quadruplets or something like that, you want to get going as fast as you can. If you're going to deliver on scene and it's a normal delivery, these are the things that you want to do. So you set up a delivery area, preferably out of view. You administer oxygen as needed. Drape the mom with the blanket. The little like drapeling that comes in the pack is nothing. It just essentially dissolves with any fluid contact. There's a lot of fluid in a delivery, so just throw that thing away. Drape the mother with the blanket from the back of the gurney. You want to have your ALS partner start an IV. They want to consider maybe some pain meds, fluids, definitely placing the mom on a cardiac monitor, but your paramedic partner will know what to do. Place the mother in a position of comfort for delivery. So usually that's semi-Fowler, so that's kind of what you would imagine a patient giving birth. But sometimes they want to squat, they want to be on their knees. Whatever they want, they get. So just as long as it's safe for the baby. And if you have the opportunity and the resources to monitor the fetal heart rate, you would want to do that as well. So you're going to coach the mom through breathing between contractions and pushing with contractions. So she's going to breathe in between them and push out and hard and down with the contractions. Obviously, ensure that you have proper PPE. This is extremely messy. There's lots and lots of fluid. There's lots of blood. So you want to make sure that you're wearing gowns, a face shield, a mask, and gloves, and preferably the ones that go up to your elbows if you have them. You want to control her crowning with gentle upward pressure and support the head as it's delivered. That's going to prevent the mom from tearing too badly. You slide your fingers along the neck to ensure absence of nuchal cord. So if the cord is wrapped around the neck, you just get the cord, you just slip it over the head real quick. And then you guide infant's head downward to deliver that first shoulder and then the rest of the body will deliver really quickly. You clamp and cut the cord. You place the first clamp 10 centimeters from the infant and place the second clamp 5 centimeters above the first, and then cut in between. So that's the really important piece, that you clamp on either side and you cut in. And it's absolutely appropriate if the dad is there and he wants to make that cut and neither mom or baby are in distress, you can absolutely let him cut. You don't want to take that opportunity away if everyone is stable. So you would wipe infant's face clean and suction only if meconium staining is present. Dry the infant's body vigorously, then cover the infant's body in a warm blanket. Cord will lengthen and the placenta will deliver eventually. So just be prepared for that and don't really start moving or like getting into the back of the ambulance before that placenta has delivered. You would place the infants on the mother's chest as soon as possible and encourage breastfeeding if she wants to. If she has no desire, that's okay. You just want to do skin to skin contact if you can. Perform fundal massage if bleeding is severe. And at that point, that is not a normal delivery, and so that needs to be an ALS provider. If not transporting already, initiate transport to an appropriate facility. So if the baby is already out and they're stable, this would be transporting to a hospital that normally like delivers babies, not just like a little community hospital down the street. So you're going to do an APGAR score on the baby. You do an APGAR score at 0 and 5 minutes. Essentially, you're just scoring them between 0 and 2 points, all of the things that you see. So appearance, if they're pink, then they get 2 points. If they have a pink body and blue extremities, that's 1 point. And if they're blue and pale, that's 0 points. So you kind of see how that works for appearance, pulse, grimace, activity, respirations. So normally the baby isn't going to score 10 points right away. Most of the time their body is going to be pink and their extremities are going to be blue, so they're going to lose a point there. And their respiration sometimes can be slow. They're not crying right away. That's okay too. So it's okay just as long as they're above a 7. So that's normal. Breech presentation. So this is when the baby comes bottom out first or both feet. So that's 4% of all live births. You want to avoid field delivery if possible. And you would want to hand this over to an ALS provider, obviously, because this is not a normal delivery. If field delivery is unavoidable, you support the buttocks and the legs. You absolutely never, ever, ever pull on the baby. If the head does not deliver after 3 minutes of crowning, an ALS provider will insert a gloved hand into the vagina. They will form a V on either side of the infant's nose and push the vaginal wall away from the infant's face. So you're just creating a way for the baby to be able to breathe. Limb presentation, you just don't want to attempt field delivery, so you need to get going. This is if they have one leg or one arm protruding from the vagina. This is super rare, less than 1% of all live births, and it's more common in like little preemie babies that kind of can turn in weird ways inside. You would transport in knee to chest position to the nearest appropriate hospital. So you just push the mom's knees to the chest. And a lot of the times you're going to need to help her do that. Multiple gestation, so twins, manage as a normal delivery, call for additional units and personnel. You definitely need at least another ambulance, because if you have a problem, if you have a baby that's in distress and a mom that's in distress, you wouldn't have enough hands. And if all of them are in distress, you're really down hands. So the minute that you get dispatch information that you have maybe a mom with twins that's attempting to give birth, just get another unit rolling. You can always cancel them. Always transport twins and triplets to the hospital, even if a midwife is there. It's important that if you assisted, that a physician takes a look at them, mainly because they're preemies. 40% of multiple gestation births are preterm. Prolapsed cord. This occurs when the umbilical cord precedes the fetal presenting part. Can result in lack of circulation to the infant, which is a life-threatening situation. It's kind of common, occurs in 1 in 250 births. So you would attempt to transport immediately in the Trendelenburg position, so the head is below the height of the hips. If umbilical cord pulses are absent, an ALS provider is going to do the same thing, insert a gloved hand into the vagina and lift the vaginal wall away from the pelvic bone and the cord. So you're trying to get the cord pulses back. Do not pull or push cord back into the vagina, and keep the cord moist and as clean as. Shoulder dystocia. This occurs when the shoulders are larger than the infant's head. There's a reason that a baby's head is so big at birth. It's because you want the shoulders to be able to deliver. So a turtle sign, that's when the infant's head will deliver normally, but then the head will retract back into the vagina as the shoulders get stuck. So you would perform the McRobert maneuver. So you drop the mother's hips off the end of the bed, have the mom flex her thighs upward to facilitate the delivery, and you push super hard down on the pubic bone, and that's kind of getting that shoulder to go down and be delivered. Nuchal cord, it's pretty common, it's rarely life-threatening. You just slip the cord over the baby's head really quick. If it's wrapped too tight, you just clamp and cut, just like normal. So it's not a super big deal. A lot of babies are born with their cord wrapped around their neck. So some pregnancy-related complications. So preeclampsia is a pregnancy-related complication characterized by high blood pressure. So hypertension during pregnancy is the most common sign and symptoms, but preeclampsia has major effects on the liver and the kidneys. Hypertension usually begins around week 20, and they might not even know it because it's pretty slow sometimes, but usually they'll have been told by their physician. Treatment for preeclampsia is usually bed rest, low-dose aspirin, and calcium supplements. Obviously, that's going to be through their physician and not through you. However, you might be called if the patient transitions from preeclampsia to eclampsia. So if a pregnant lady has a seizure and she doesn't have a seizure disorder, you're going to assume that it's an eclamptic seizure. So this is an ALS level call. It is treated with magnesium sulfate, but a paramedic will know what to do. Essentially, you just treat this like any seizure. You get things out of the way for her. Your paramedic partner is going to be trying to get a line, but that's what's going on, is that the high blood pressure is causing a seizure in the mom. And so now she's having an eclamptic seizure. So benzodiazepines are not going to work. It's treated with MAG. Most of the time, an emergency C-section is performed at the hospital after an eclamptic seizure. So the patient absolutely must be transported. Spontaneous abortion, also known as a miscarriage, means loss of a pregnancy before 20 weeks. Occurs in approximately 20% of known pregnancies, with approximately 50 due to some sort of chromosomal abnormality. So it's pretty common. 20% of women will have spotting or bleeding before 20 weeks, and 50% of those will end in a spontaneous abortion. So if didn't reach that 20-week mark and they're having bleeding, you would want to transport them because they might need a D&C. Field treatment for possible spontaneous abortion is an IV, cardiac monitor, airway control, and immediate transport to the nearest hospital. So any hospital is going to be okay because she might have a massive hemorrhage, and so she needs blood. D&C will likely be performed at the receiving. And postpartum hemorrhage. So this is after the woman has given birth, then she hemorrhages. It's usually more than 500 milliliters in a vaginal delivery, or 1,000 milliliters in a C-section. So it's a ton of blood, lots and lots of blood. The causes, the 4 T's. So tone, she can have a soft or boggy uterus. That's in 70%. She could have trauma, a genital tract tear, some sort of trauma from the birth can cause the hemorrhage. Tissue, or retained placental or fetal membranes. That's why you always want to check the placenta to make sure that there's no piece remaining inside. And thrombin, so the blood is not clotting. For some reason, she's just not clotting, and that's why she's having a hemorrhage. You would do an active management of the 3rd stage of labor, 2 large bore IVs, oxygen, monitor the vitals closely, have blood available if you can. That means if you are transporting at this point, going to the nearest hospital because you need blood. Ectopic pregnancy. So this occurs in about 1 in 100 pregnancies. An ectopic pregnancy is defined as a pregnancy that occurs outside the uterus, with 95% of them implanting in the fallopian tubes. So remember that very first slide that we looked at, that if they don't make it all the way down to the uterus and they implant in the fallopian tube, then that would be called an ectopic pregnancy. Most commonly presents with extreme lower abdominal pain and vaginal spotting. Some major risk of tubal rupture, can and will quickly become hemodynamically unstable, and presence of hypotension with acute abdominal pain in a childbearing aged women may indicate rupture. So any woman who has the ability to be pregnant, is sexually active in some way, and has hypotension and acute abdominal pain, you have to assume it's an ectopic pregnancy until proven otherwise. It's a life-threatening emergency. They need to be going to the hospital as soon as possible. And an amniotic fluid embolism. So this occurs in 1 to 12 out of 100,000 deliveries. They're unpredictable and unpreventable. They have an unknown cause. Amniotic fluid or other fetal cells enter into the maternal circulation and triggers an inflammatory response with activation of the coagulation cascade. So essentially they go into DIC. So the first stage is cardiopulmonary collapse. So the hypoxia, capillary damage, left heart failure, which turns into ARDS. And the second stage is the hemorrhage. So they have massive hemorrhage, uterine atony, and then DIC. So a lot of patients die from this. Maternal mortality of approximately 20%. So 20% of women that have this will die. And 85% will have significant neurologic injury. So they're going to have a brain damage because of amniotic fluid embolism. There just isn't anything that we can do, especially out in the field. But if you start to see signs of the coagulation cascade, get them to the hospital as soon as you possibly can. This is why we always transport. You always want to transport. A lot of the times, moms want to stay home with their baby if they seem like they're healthy, but you never know if they're going to throw that clot. So you always want them to be in the presence of a physician, close to blood, all those kinds of things.
Now let's transition into some multiple choice questions.
Question number 1. You are dispatched to a woman in labor. Upon arrival, the mother is screaming that she is ready to deliver. Your history reveals that she's had 3 children and 2 previous abortions. You could best document this history by which of the following? A. Para 6, Gravida 3. B. Gravida 3, Para 2. C. Gravida 6, Para 2. Or D. Gravida 6, Para 3. The correct answer is D. Gravida 6, Para 3. Remember that gravida or gravidity refers to the amount of times the patient has been pregnant. Para is the number of viable children that have been born. Question number 2. Upon delivery, how do you suction a newborn's airway? A. Mouth first, nose second. B. Rub the child's foot to stimulate the coughing reflex. C. Nose first, mouth second. Or D. Use an infant-sized French catheter and do this for no more than 5 seconds. The correct answer is A. Mouth first, nose second. Using a bulb syringe, you must suction the newborn's mouth, then the nose. This helps prevent the newborn from aspirating any of the contents that may be present in their mouth. Question number 3. In order for an infant to be considered premature, they must be born before how many weeks of gestation? A. 27. B. 35. C. 36. Or D. 37. The correct answer is D. 37. Any delivery before 37 weeks is considered to be premature. Premature babies can have an increased risk for complications and issues that may occur at birth. Question number 4. For postpartum bleeding to be considered a postpartum hemorrhage, there must be how much blood loss? A. 2,000 milliliters. B. 500 milliliters. C. 1,000 milliliters. Or D. 1,500 milliliters. The correct answer is B. 500 milliliters. Only 500 milliliters of blood loss is needed to be considered postpartum hemorrhage for a patient. This can be managed by performing a fundal massage or the administration of oxytocin, depending on the protocols you are working within. Question number 5. When does the second stage of labor end? A. After cutting of the umbilical cord. B. When crowning is present. C. When the delivery of the infant has occurred. Or D. When the delivery of the placenta has occurred. The correct answer is C. When the delivery of the infant has occurred. The second stage of labor occurs from full dilation of the cervix to delivery of the infant. Remember that the first stage of labor goes up to full dilation of the cervix, and the third stage of labor starts after the infant has delivered and ends once the placenta has been delivered. Question number 6. The term antepartum is which part of the pregnancy period? A. Pre-delivery. B. During delivery. C. Post-delivery. Or D. When excessive bleeding occurs during the delivery. The correct answer is A. Pre-delivery. When a woman is in the antepartum period of the delivery time, she is in the pre-delivery phase of the pregnancy period itself. Remember that the term postpartum refers to post-delivery or after the baby has been born. Question number 7. An ectopic pregnancy is one that occurs A. Inside the uterus. B. Along the urethral lining. C. Inside the bladder. Or D. Outside the uterus. The correct answer is D. Outside of the uterus. An ectopic pregnancy is one that occurs outside of the uterus and most commonly occurs within the fallopian tubes. Question number 8. Your patient is a 24-year-old female complaining of abdominal pain. She is 19 weeks pregnant and is gravida 2, para 3. Her last pregnancy was carried to term with no complications during delivery. She has been seeing her OBGYN regularly and is taking prenatal vitamins. The patient states her pain is located in the upper right quadrant of her abdomen, and she has also noticed that her hands and feet have been very swollen recently. She denies any vaginal bleeding. Which of the following is a possible differential diagnosis for this patient? A. Placental abruption. B. Preeclampsia. A. Mittelschmerz. B. Preeclampsia. C. Placental abruption. Or D. Uterine prolapse. The correct answer is B. Preeclampsia. Mittelschmerz pain is not possible because a female does not ovulate when she is pregnant. Uterine prolapse is extremely unlikely for this patient, and the patient denied any vaginal bleeding, which is usually present during a placental abruption. Therefore, preeclampsia is the best answer. Upper right quadrant abdominal pain and swelling of distal extremities are also signs present with preeclampsia. Question number 9. Which 3 of the following changes would you most likely see with a pregnant adult female? A. A decrease in heart rate. B. Edema in the hands and feet. C. An increase in heart rate. D. Hypotension. The correct answers are B, C, and D, which include edema in the hands and feet, increased heart rate, and hypotension. Depending on where the female is in her pregnancy, you will at some point see all the following changes, except a decrease in heart rate. This question is referring to the changes that are maintained and not the ones that are acute or temporary changes. Question number 10. You have been dispatched for a pregnancy problem on a highway. The patient is in labor and her husband was driving her to the hospital when she felt the urge to push. You find one female patient in the back seat of the car. Vaginal examination reveals crowning. The woman states that she has been pregnant 4 times and has 4 kids. Each labor has been shorter and her last child delivered in less than 10 minutes. What is the patient's gravida para score and what should you do next? A. Gravida 5, para 4, and prepare for immediate delivery in the car. B. Gravida 4, para 5, and ride with the patient in the car to the hospital. C. Gravida 4, para 5, move the patient to the back of the ambulance and initiate rapid transport. Or D. Gravida 5, para 4, and move the patient to the back of the ambulance and prepare for delivery. The correct answer is A. Gravida 5, para 4, and prepare for immediate delivery in the car. Providers should always prepare for imminent delivery when the head is crowning during a delivery. Even the subtle movement of standing to sit on the gurney could result in delivery of the infant. When referring to the Gravida para score for this patient, she has been pregnant 5 times, including this current pregnancy, which gives her a Gravida score of 5. And with currently having 4 children, this gives her a para score of 4.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to EMTprep.com. Until next time, stay sharp, stay safe, and stay on pulse.